Hello, this is Dr. Luke Rebenitsch at ClearSight Center in Oklahoma City. This is the dysfunctional lens replacement, or DLR. So this is a patient in late 40s who was struggling with bifocals. The patient does not have a cataract, but just had normal age-related changes, and so we're doing this elective procedure in order to improve both distance and near vision. What we do here is, first we're adding viscoelastic or OVD. This is a gel that helps keep the eye formed. We make our two openings. One is 1 millimeter, the other one is 2.4 millimeters. Here we're making an opening in the anterior or the front capsule. Here we continue this. This is called the capsular rhexis. We want this to be as circular as possible. We want it to be just big enough to allow the optic clear access to the front of the eye, but small enough to allow overlap of the lens. Here we are doing hydrodissection using saline in order to dissect the lens. Now we're using ultrasound. Now keep in mind this is all at 1.5 speed. This is what we call it. This is the Pac-Man technique and the carousel. So what we're doing is making a small groove into the lens, which is approximately 9 millimeters in diameter and 5 millimeters in width. You can see this is a relatively soft lens. This was a hyperopic or farsighted patient, again struggling with near and distance. Here we can see that we are finally able to move the lens, and here we just rotate the lens into the anterior, the front part of the eye, and remove the nucleus or the innermost aspect of the lens. Using the other instrument, the second instrument, in order to prevent the posterior, the back of the capsule from coming forward. Here we're doing irrigation aspiration. Now removing the outer cortex. We've already removed about 95% of the lens. Now we are removing the remaining. This cortex tends to be fairly sticky. We're not using any ultrasound at this point. It's purely just aspiration and irrigation to keep the eye pressurized. All right. Now we use the capsular guard technology here to prevent any rupture of the posterior capsule. There I was using the polish setting in order to remove any remaining stem cells. There I placed OVD or viscoelastic in order to form the eye. And here is the new multifocal lens. Multifocal lenses work by splitting light. They are diffractive. They are different than the contact lenses that are multifocal. Now this is a game of microns. This lens needs to be lined up along the patient's line of sight, which is not the center of the pupil, but toward the nose and down. You can see there are a few, you can see that there is a few cells or lens cells posterior to the lens or behind the lens. And so here I'll be using the IA tip in order to remove those cells. We want a perfectly clear path from the front of the eye to the back. By removing all of these cells and doing a good cleanup, we're less likely to need to do the YAG polishing laser in the future. Okay, I'm removing all the remaining viscoelastic. I'm reinflating the eye with basic salt solution or saline. I'm tapping down the lens to again make sure that there is no viscoelastic behind the lens. And the last thing I'll do is place an antibiotic, which decreases the risk of infection by about 2/3. And the eye is pressurized to physiologic pressure, and that is it.